Today, for metastatic colorectal cancer patients, we do have different options that may be chosen based on several drivers of our choice. The first driver, in my opinion, is now a molecular marker, which is microsatellite instability, because in the presence of deficiency in the mismatch repair system, then we need to go for immunotherapy. Immunotherapy, that is checkpoint inhibitors and mainly pembrolizumab as upfront option, is the best treatment we can offer a patient with a dMMR or a microsatellite unstable tumor. On the other side, other drivers are important for those patients that do not bear an MSS or proficient mismatch repair tumor. For these patients, we need to look at the patient's characteristics in terms of fitness and understand whether these patients are fit or not enough to receive a combination of chemotherapy. If the answer is no, then the choice of a mono chemotherapy is not a real choice but a need due to patients' characteristics and comorbidities, much more than a choice based on the apparent indolence of the disease or the low tumor burden. So in the case we can choose a combination chemo, then based on primary tumor side and RAS and BRAF mutational status, we may make our choice in terms of targeted agent to be combined with the chemotherapy. In left-sided and RAS and BRAF wild-type tumors, the first choice is doublet plus an anti-EGFR. This has been very well demonstrated in several clinical trials and also some trials that have been presented and will be updated, or new trials that will be presented at this ESMO Congress. For sure, they strengthen the role of doublet plus anti-EGFR as upfront option for patients with the left-sided and RAS and BRAF wild-type tumors. For right-sided and RAS mutant, we have the triplet FOLFOXIRI plus bevacizumab as first choice in those patients that are young and fit enough to receive this treatment, otherwise a doublet plus bevacizumab. And for BRAF mutant patients today, the first line is still chemotherapy plus bevacizumab, mainly FOLFOX plus bevacizumab. There is less convincing data about using the triplet in this subgroup as compared to the past and the initial insights from subgroup analysis of the TRIBE study. But in the next future, probably for BRAF mutants, we will have a targeted option that is today available starting from the second line of therapy, but will hopefully, based on the results of the Breakwater trial that is currently ongoing, will be probably brought in the first line of therapy.